We are live.
Good evening, everyone. So we are back with another class of retina module, and this is a very important class for all of you because not only this is important for your day-to-day practice, but also from exam perspective. In exam in Grand Viva, they may give you some images and ask you interpret this. So this is going to be a very important lecture, ultrasound in retinal diagnostics, and for today's lecture, we have Dr. Sandhya Makhija ma'am with us. And Sunil, have you shared the PPT? So, ma'am is currently the Vitreous faculty at Sant Permanent Hospital. Sunil, am I audible to you? Please share the PPT. I think you stopped sharing the PPT. And so, ma'am is currently the faculty at
This one
Sant
is
Permanent.
previous. This one is previous one.
Wrong.
Hmm.
Okay, so whatever I know about ma'am, I'm going to introduce her in that way. She's a very good teacher, and especially ultrasound. I have seen her taking lecture in our DOS events, and luckily she agreed on a very short notice to take a class on ultrasound for you people. She has done her graduation from Lady Harding LHMC, post graduation from GNEC MAMC, senior residency from ICAR Noida. She's a fellow Retina Foundation. Also, she's a fellow ICO Belgium. She's a fellow Newark Eye and Ear Information. So she has a lot of experience in retina, and currently she's practicing, as I said, at Sant Permanent Hospital and Shyamlal Eye Hospital. She has many recognition and achievements to her name, and you must have seen her presenting papers, talks, lectures, especially WAS platform. Also, she is very active, and currently she is the head of the WAS chapter, Delhi chapter. She has participated as faculty in multiple programs, including the renowned VRSI, which is specifically dedicated for retina specialty. And she has been a panelist in many national and international conferences. And the last point is very important for us. She has been an examiner as well as thesis assessor for various DNB programs. And just to remind you, ma'am, this in our program we have an association ANBAI, which is the association for NB affiliated institutes, and also we have almost 700 students who have uh, registered for this program. And out of 700, I was going through that list. Almost 200 plus students are DNBs. So I think the our students will be extremely benefited by your lecture today. And for this retina module, we have Professor Lalit Verma as our chairperson. And today, I hope he joins. And we are extremely grateful to him because he helped me in preparing the module and also deciding the speakers for each talk. And sir is currently at Center for Sight, but he is an ex-alumni from RP Center, ex-associate professor RP Center, and extremely experienced in retina. And I think let's start with the talk. Sumit, I think you can stop. Yeah, ma'am can start her lecture.
Thank you so much, Dr. Praful, for such a nice introduction and having me here for this wonderful job you're doing. The whole DOS team, I'm really thankful to you all. So this is a very important topic, like since we are going into the retina module, and once we talk about retina module and for retina people, and once we talk about retina diagnostics, I think ultrasound B scan, like you very rightly said, is a very important topic, practically also as a retina surgeon also, and on the same time for students also for their exams and everything. You may get a long question, you may get a long question on just a short note, maybe on how do you see a PVD, or some small things. And in Viva, definitely examiners are going to catch you and ask you a lot of things about it if you get a retina case shortly. So let us start with the talk, and then we can have all the discussions later on. And I will be very happy if we have a lot of interactions and discussions in the end. or in between also, whatever questions you all have, you may send your questions and let us have a good interactive discussion since this is a very practical topic. So should I go ahead with the slides, right, Dr. Praful?
Yes, ma'am.
Okay. So let me start with some basic things. You all know what is an ultrasound. These are just acoustic waves in inaudible range, right? It was first used by military people way back in 1916. And when we talk about ocular diagnostics, it was first used by Munt and Hughes in 1956. In fact, first 2D B scan was done by Baum and Greenwood. That was way back in 1958. We just talk about some basic physics before we go ahead. What is the principle? The principle is the pulse echo technique. See, there are pulses of ultrasound waves which are emitted. There is a transducer, and from there, the waves are emitted. Echoes are produced by the acoustic interface it goes through in between the returning signal, because the acoustic interfaces, they act like a reflectors. So the returning signals are detected, amplified, and displayed by another machine or a chip. Then it's displayed, and that's how you see the display. It has various uses, both diagnostic and therapeutic uses. So I'll be just talking about it as we go ahead. Uh, in ophthalmic diagnosis, what is the importance of ultrasound? It is a very important non-invasive investigation of choice, especially once we have an opaque media, then we don't know what's happening behind. So it is a very important diagnostic tool. High frequency in the range of 8 to 10 megahertz are used in our ultrasound. If you just recall in abdominal ultrasound, there are various frequencies, even up to 50 megahertz, abdominal ultrasound in between 1 to 5 megahertz. So here in ophthalmic ultrasound, we use the frequency of 8 to 10 megahertz. This is also a very important question. A lot of examiners might ask you. So there are different modes: A scan, B scan, C, D, M, and so on. But mostly you must be doing A scans routinely in your OPDs. Your senior consultant must be telling you, okay, A scan kar do. So what is A scan? It is just a two-dimensional, it's like a linear scan that you routinely do in your biometry. So that is A scan. Then we have two or three dimensional, which is the B scan, and then further on there are a lot of other scans also. But as far as we are concerned, you people are concerned, A and B scan is the most important scan. Basically for you people. So again, coming to techniques, there are different techniques: contact scan, immersion scan, and again, mostly we will do just contact scan. We do most often for our B scans, posterior segment purposes. Immersion scan sometimes you do when you're doing A scan, and you're planning for a higher end biometry, a higher end optical, all those things. Then there are different modes of examination. There are topographic, kinetic, holographic, biomicroscopy, Doppler. And as far as our B scan is concerned, mostly we're doing topographic or kinetic. Again, I'll be telling you that what are these scans in later in my slides. Then there are 3D ultrasound imaging, compounding of different modes, different scan. It gets compounded, and some softwares, they do job and make a kind of a 3D picture. So these are all advanced things, especially now with artificial intelligence also coming up. So with sub advanced machines. So these are just newer advances. But when we come down to the basics, basically we are doing a simple B scan. So that will be discussing today in our class. So this is the probe with the transducer. It is a small contact area probe of ophthalmic B scan. It's a curvilinear. It's a small, the width is somewhere like comparable to the width of the eyeball. It has a piezoelectric crystal, and there is a marker. You can see this marker in this picture. So this marker represents the top of the screen, because whatever the reflected acoustic interfaces and whatever picture we see on the screen. So the top pen shows where this, because you'll be rotating this transducer, this probe. So wherever the marker is, that is the top end of the screen for your reference. So mostly, take it this way: we are doing the scan through the lids, and or maybe some people do directly over the sclera, but what we are showing you is doing through the lids. The technique, once the most important thing I would say, that it should be essentially done by the clinician or the ophthalmologist, like a retina surgeon, who's dealing with the case. Suppose like I am dealing with the case, I have to take the patient for surgery. So I would like to do the ultrasound B scan myself, not rather giving it to my technician that okay, the technician does the scan and sends me the images, because I want to see the orientation of my probe, that when I am doing the scan live, I want to see the orientation, the plane of the scan, the plane of the eyeball, that I have to see images and I have to correlate what I'm seeing in that plane, what is happening in the eye, where is the proliferation, where is the detachment, where is the membrane, or where is the PVD, and all those things. So it is always advised that the clinician should do the scan yourself. Many times, many places I have seen that people advise B scan, and the patient goes to a radiologist and get the scan, and comes back to you. I will never encourage that. Probably it's never going to give you the information that you want as a clinician, as an ophthalmologist. So do scan yourself. Insist on having a combined A scan. So what is a combined A scan? Now you are doing a B scan. You're seeing a two-dimensional, or a the whole image on the screen. So combined A scan means there's a line of A scan spikes that is also showing you, at the bottom, that how is the reflectivity is like high or low. So you were seeing a linear scan, kind of a linear scan at the bottom, which is combined with your B scan images. So it gives you a very good idea of the structure, whether it is low reflective, high reflective, medium or moderate reflective, it's the capsule, it's foreign body, or whatever. So it is a very good thing to have a combined A scan. I will show you the pictures, then you will get a better idea. So start with basic screening of the entire globe. You look for the orientation of the probe, see the orientation according to the lesion. You should have that lesion in your mind, that, what are you looking? You just can't just start blindly. You should know the patient, the clinical history, a good clinical examination. Fundus, try to have a fundus examination. So at least you should know the case. So then only you start with B scan, because then you should know what you have to look for. Try and localize the lesion, whatever lesion is in your mind, whatever lesion you want to see, try and localize it. You look for the quadrant, you see what is the extent of the lesion, you see the position of the lesion, and then you start seeing, the lesion in more details. So since now we are in the retina module, so I will be focusing only on the posterior segment disorders. Otherwise, ultrasound has a lot of anterior segment pathologies also that you will see. But I think in this class, I'm concentrating, I'll be focusing only for the posterior segment disorders. So in posterior segment, you should first know what you see normally. What is the normal anatomy that you see, once you are doing a ultrasound B scan. So in ocular scan, this is the normal picture that you see. This is probably a little aged patient. That is why you're seeing little echoes in the posterior vitreous cavity also. Otherwise, the posterior vitreous cavity is by and large unequal. Sometimes you see these kind of mild echoes in, because as I told you, some aged patients having some mild age-related degeneration, that's okay, but this is pretty normal. Amongst the anterior segment structure, you see only the shadow of the posterior capsule, nothing else. You don't see much anterior things, here. If you want to focus or you want to see anterior things, probably you'll have to revert to an immersion scan. But once you're doing scans transclerally or directly over sclera or over through the lids, you are seeing only this posterior capsule and then beyond. This vitreous cavity is by and large anechoic. This is the scleral shadow that you are seeing. And behind the sclera, you are seeing this dense retroorbital space shadows. And here you see a shadow of optic nerve. I hope you're seeing my marker on the screen. So here you are seeing the shadows of optic nerve. This is the optic nerve head shadow. This is the optic nerve head. And some macula, I will show you in some more pictures where you see macula, but normally you don't see. Vitreous is relatively equilucent in young people. In adults, you might see some low reflective vitreous echoes due to syneresis. And again, also with age, it may have little more of syneresis. So in vitreous cavity, what are the majorly pathologies that you see is a PVD. You might see asteroid hyalosis, different shadows of asteroid hyalosis. In vitreous hemorrhage, you have to see the ecography pattern depending on the duration and severity of the hemorrhage. What you have to look for is ecodensity, membranes, any movements, any tractions, any detachments, and you have to look for cause of hemorrhages like a tear, trauma, or sometimes proliferations also you can catch. So these are the different pathologies of vitreous hemorrhage that you see. You see here the first picture is a fresh vitreous hemorrhage where the whole vitreous cavity is full of, you know, mild generalized scattered echoes. You don't see any membranes in the backside of the vitreous cavity. Do you notice here? Now, this is the combined A scan spikes. This is the linear A scans at the bottom that you are seeing. Like in front, this is the A scan linear line, and you are seeing these corresponding A scan spikes at the bottom. So this is the linear line. Like here, this is the posterior capsule, and the A scan spike is very high, the corresponding spike. In between, the spikes are low to medium, and as it goes towards the back, this is because a little more dense hemorrhage, so the spikes are a little more rising. And once it hits the sclera, the spikes are again high, sclera and choroid. This is where the vitreous hemorrhage gets the second picture on the right. The hemorrhage starts getting organized now. You are seeing the membranes little more clearly. These are the posterior vitreous phase, the detached phases like a little PVD. And in between some vitreous membranes, because it is getting organized, the hemorrhage is getting organized. And the corresponding A scan spikes, now you see wherever this line hits the membrane, the spikes a little higher. In between, the spikes are low to moderate, in fact, lower on this side because now the hemorrhage is resolving. So the A scan spikes are a little lower now. And as and when this is, even more advanced stage of vitreous hemorrhage, in the sense maybe few more months have passed and now the tractions are even getting formed even more as compared to this picture. Now here, this is the the bottom left picture. The tractions are getting more, the PVD is getting more organized, and there is some subhyaloid hemorrhage also, like behind the vitreous membranes, the vitreous phase. Some hemorrhages here also coming up. And in the bottom right, there is a vitreous hemorrhage with a detachment. Now you see this membrane of retina. Now the retina is also detached. It is getting focused or stuck or converges to the optic nerve head. And this is a little thicker membrane if you see. And if you see this, notice this is a small, thin, tiny membrane. So this is a PVD associated with a retinal detachment here. And if you see the corresponding A scan spikes here, now this is a higher spike, okay? This is the higher spike because this line is now passing through the retinal phase. So this is higher. So this is how you know it's a retinal shadow because the A scan spike is little higher in the retinal shadow, whereas this intersection with PVD, the spike is little lower. So this is an advantage of having a combined A scan, You can find out whether that membrane gives you a higher spike or a medium or a low spike. Typically, a retinal membrane, a foreign body, a fibrous tract where it is like densely fibrous, that will give you a higher spike on a combined A scan. So again, this is a subhyaloid hemorrhage. This is a pure subhyaloid hemorrhage. This is that posterior vitreous phase. And there's a big hemorrhage behind the vitreous phase in between the retina. This is the retina and posterior vitreous phase. So this is how what subhyaloid hemorrhage will look. This is how pure vitreous hemorrhage where the subhyaloid space is clear. This is how the vitreous hemorrhage will look. And what will now? If you just remember, I was talking about kinetic sonography in my first few slides. So, what is a kinetic sonography? Kinetic sonography is When you're doing the ultrasound and then you ask the patient, your probe is over the eye, and then you ask the patient to move the eyes right and left. Now, PVD will be a thin undulating membrane. It could be a partial or complete. That's a different thing. And it will have a distinct after movements in the sense that you're putting the probe on the patient's eyes and then you ask the patient to move right and left his eyes. And then you ask the patient to stop moving the eyes. So patient will stop moving the eyes, but the PVD, the membranes are still moving. So I'll just show you. I have this uh, video of a PVD. So this is how a PVD will look on a kinetic sonography. You know, you are doing the ultrasound and you're asking the patient to move the eyes right and left. And no, I think, wait. Okay, this is PVD. And moment you ask the patient to stop moving your eyes, moving his eyes, the undulating membranes are still moving. See how freely it is moving. Okay. So this is how a PVD will look like. How about retina and choroid? So retina detachment is a highly reflectile membrane. A fresh RD will be relatively mobile, whereas old RD with PVR changes will be little stiff and little stiff to move, little immobile. It will extend from aura. If you see the extent, it will extend right from aura till the optic nerve head. And then you have to look for tractions, any membranes, any tears or flaps. And you also have to differentiate from a retinoschisis. A choroidal detachment, whereas, will be more smooth, thick, it will be dome shaped, and it will be usually located on the periphery because it is usually over the vortex veins or little on the equator. Of course, if it is a large choroidal detachment, it will come down till the posterior pole. Sometimes we do see kissing choroids, whereas like both domes of choroids are almost touching each other and it is going right up to the posterior pole. And if we see the corresponding A-scan spikes, it will be a double spike. Typically, choroidal spikes are typically M-shaped spikes that we see, the double spike. And it is highly reflective, but little less so as compared to the retinal shadows. And virtually there will be no after movements. Like when we do a kinetic sonography and we ask the patient to move and then to stop moving the eyes, the choroidal shadows or the choroidal membrane will stop. They will not show after movements, they will stop moving. They will be little stiffer as compared to a PVD. So like this is a retinal detachment starting from aura, converging up till the optic nerve head. And you see that this is the corresponding A scan line and A scan spikes. It is so high. And especially when we reduce the gain, the retinal shadows, the retinal spikes will still be high, once we reduce the gain from the machine. And this is how a choroidal detachment will look like. There is some overlying retinal detachment also in this area. Full or no, I don't remember. This was an old picture. So that's what we have to see whether the extent of RD is complete or no. But definitely we are seeing a choroidal detachment here in this scan. And if we see the A scan spikes, corresponding A scan spikes, this is a retinal spike, this is a little higher, whereas this is the choroidal spike, little lower as compared to this retinal spike. And all the rest of the spikes are moderate, and these are the scleral spikes behind the scleral choroid, which are like just moderate. So this is the combined retinal and choroidal detachment, and I will show you the video also. Okay. You see, once we ask the patient to move, the choroidal membranes are little thick and stiff, whereas retinal membranes are little more mobile. And you see these choroidal shadows, choroidal detachment is just not moving at all, whereas the retina is moving little more. And PVD will be moving even more. This is how we see. Okay. So next we come to intraocular tumors. Now, ultrasound is very important. In fact, I would say it is most important. It is invaluable investigation for choice. It is more for follow-up rather than diagnosis. Diagnosis, so definitely we will do with ultrasound, but it is more important for following up the patient. Now we have diagnosed that okay, the patient has some intraocular tumor. We are giving whatever treatment we are doing, and we want to know that whether the whole lesion is increasing, decreasing, what is happening in the middle of the lesion, the internal lesion, how it is behaving. So ultrasound is the only thing, only way that we can know that what is happening within the lesion, outside lesion, the size and everything. So it is very important for follow-up actually, rather than diagnosis. So what we have to look for when we are talking about intraocular tumors, we have to look for position, shape, size, extent. We look for internal echoes, internal reflectivity. We look for surface, margins, base of the lesion, and any sound attenuation behind the lesion. How's the vascularity of the lesion? Is there any associated pathology like vitreous hemorrhage, vitreous spread? There is, associated detachment. So we have to look for all those things, what is happening along with tumors. So these are all intraocular tumor pictures. Like we see the top left one, okay? So this is a typical melanoma. You see, typically it is mushroom shaped lesion. It is a mushroom button shaped lesion, posterior pole or little on the periphery also it happens. We see very commonly. So it has a stump. So again, like I told you, we have to look for size, we have to look for shape, and whenever we are serially following this patient after whatever treatment, so we have to see whether it is increasing, decreasing. So we note down the shape and everything, and then we see how it is behaving after treatment. Internal echoes are also high because it is a melanoma. It is full of melanotic cells, and they're all highly reflectile. So internal reflectivity is very high. You can see the internal, it is full of internal echoes. So this is how typically a melanoma will look like. The top right one is hemangioma. These are little flat shaped tumors and mostly on the posterior pole. It can be a small or big one. That is a different thing. So that is what we have to note. We have to note the size, and we have to note, the location, the extent, and all those things. Like we do, like when in our MBBS time we were studying lumps and masses. That is how we used to describe and we used to note them. So here also with our ultrasound, we note all these parameters. So this hemangioma, like you see, the internal echoes are little lesser, little lighter as compared to, these melanomas. So these are more flat, and you see the top of these hemangiomas are also little, sometimes, they have some specks which are like more reflectile. Okay. So this is how we see them. And the top left one is a metastasis. This is how we see metastasis, because normally metastasis we see, much peripherally, not more towards the posterior pole. And we may see them, at multiple points, like we see one metastatic lesion here, one maybe somewhere else. So we have to note down these areas, which quadrant and where we are seeing, what is the extent, what is the size. So metastatic lesions also, they're like low in reflectivity. The internal reflectivities may be little low, but then they may be little uneven also. There are certain, like you see, this area is little highly reflectile, but the other surrounding areas are low, low reflectivity areas. So they're little uneven, not as even as a hemangioma. You see, this hemangioma is totally even, so even. When we come down to retinoblastoma, the bottom right is a retinoblastoma, totally uneven, and you see a lot of necrotic and calcific areas in between, some high reflectivity, some low reflectivity. I mean, you see totally different kind of picture with retinoblastoma, but then you have to definitely correlate with a lot of other things, the age group, the patient, the child, and all those things. Foreign body is one of the most key investigation probably we would like to do in ultrasound, because so many times when trauma patients come to you, your anterior segment is totally opaque or hazy. The patient may have bad corneas. The patient may have a full cataract after trauma. and you don't know what's happening behind. You get a clue from the cornea, you see some corneal injuries or some corneal entry wounds, you suspect probably there's a foreign body, but you don't know whether actually there's a foreign body, or maybe just some tract has gone inside and thing has come out, so you don't know. So ultrasound is the best investigation for that, for localizing the foreign body. And foreign bodies typically have very high reflectivity with shadowing. If there is a foreign body in the vitreous cavity, the reflectivity will be very high. Moment you reduce the gain, you stop seeing all other structures in the eye, and you just see only the foreign body. The foreign body shines like anything. And there's a shadow behind it, there's a tract behind it. Some you can even localize the tract in the vitreous cavity from where the foreign body has gone inside, from any of the sides. So yeah, once you have a foreign body there, you have to keep in mind a lot of other things also. You have to look for any pathology which is associated with trauma, like there's a vitreous hemorrhage, there's a detachment, or there's, something else. So that also you have to look for. So it gives you a lot of other clues also. Like this is the patient having intraocular foreign body, patient after trauma. Uh, you see, this foreign body is now maybe little old. There's a little fibrosis around it, and there's a shadowing behind the foreign body. And then you see some tract also. This membranes in the vitreous is giving you some clues that probably it has gone in through this route. So it many a times it leaves a tract, and there is a there's a whole fibrosis, as I just told you, and then some vitreous membranes. There is a PVD also, but thankfully there's no detachment at this point. So all these things you have to note down once you see a foreign body. And moment you reduce the gain, you don't see any other structure, and this foreign body shines out. This is the same patient. This is like a normal B scan, normal ultrasound, and this is moment I have reduced the gain in the machine, and I don't see any other structure. And this is how now it's almost confirmed it is foreign body and nothing else. Because sometimes someone might think that, this is just a fibrovascular proliferation and all these things. So this is how you confirm that, okay, this is a foreign body. This is a posteriorly dislocated eye well. Again, it's like a foreign body only. And why we need to do an ultrasound here? Maybe because at this time there must be some other associated pathology like a bad cornea or a corneal haze, that that we cannot see fundus, and so there moment we do an ultrasound, then we know that the IOL is not at the place where it should be. It is dislocated behind. So this is how you see like a dislocated IOL. You see the convexities of the optics lying there in the posterior vitreous cavity. Intravitreal cysticercosis is again a very uh, good pathology where ultrasound is very useful. We see the whole scolex here. This is the whole cyst, and we see the scolex, and you see the reflectivity of corresponding A scan. It is so high, and so many times we catch live cyst. The cysts are moving because it is a live cyst, and the scolex and everything, it is moving. So we know that, okay, we have a live cyst, and what we have to do next to treat the patient. Okay, many a times we do uh, vitreoretinal surgery, for RDs and all those things. We put oil, the patients keep coming us for follow-up. A couple of months later, we don't know the oil is there inside, but so many times we suspect that there is something wrong, and probably there's some subretinal fluid, there's some RD, but we're not sure. We want to know, whether the retina is really attached or no. There's a shallow detachment, there's a shallow subretinal fluid. So we take the patient for ultrasound, but it's not so easy. We don't get a very good picture on ultrasound on silicon filled eyes. Number one, why? Because once there is a silicon oil, because you know that ultrasound is all sound waves, and sound waves will travel slower in silicon oil filled eyes. So apparently the eyeball will look longer. You've noted, did you note that this eyeball is looking normal? No, it's not normal. It's little longish. It's all because the physics, because it is an oil-filled eye and the ultrasound waves are traveling slower, so there will be an apparent elongation of the eyeball. And these membranes, now we are seeing these membranes in the vitreous cavity, not sure whether these membranes are oil interfaces or these membranes are some retinal membranes, there's a subretinal fluid or no. But mostly, many a times, even oil interfaces, will give you these kind of shadows. So, uh, silicone oil fill eyes probably will not give you a very um, correct information. You have to assume a lot of things on the basis of your clinical examination and your own this thing. Macular degenerations, sometimes we can catch on ultrasound B scan. Although, I mean, this is the picture I've taken long back when we didn't have OCTs in our clinical scenarios. With the advent of OCTs now, everyone will definitely go for an OCT for any case of macular degeneration. And treatment and follow-up wise, OCT is definitely very good. But once what happens when the patient has dense uh, vitreous hemorrhage, and probably there is a macular degeneration happening, and probably a macular degeneration is the cause of vitreous hemorrhage. Even a CNVM can cause vitreous hemorrhage, right? So in those scenarios, ultrasound will come to your rescue. You cannot do an OCT in a patient with vitreous hemorrhage when you are suspecting an ARMD or a wet CNVM, which is causing a vitreous hemorrhage. So many times you have to do an ultrasound, and these large macular degeneration do catch up in ultrasounds also. Sometimes patient has mature cataract, so you do ultrasound thinking just to rule out any posterior segment pathology, and then you get a surprise and you see a macular degeneration lying behind. So, I mean, just you should have this thing in mind that you can even catch these degenerations, large degenerations on ultrasound. Of course, there are a lot of other indications for ultrasound when we talk of scleral pathologies, disc cupping, gliomas, colobomas, some other discademas or drusins, congenital anomalies like nanophthalmos and phthisis, other orbital pathologies, ruptured globe, and UBM is also a part of ultrasound. But since today we are just, talking about the retina module, so this is a separate class in itself. So I'm just listing this because you should know that, even there are other indications also. So I will be just taking few clinical cases like, but I just thought I'll show you some videos also. Okay, before clinical cases, I think we'll go on with some videos. Clean the floor gently, because it's also very important. Okay, wait. I just wanted to show how will we do an ultrasound. Oh, sorry. Okay. I hope you can see my screen. So we'll be starting with the ultrasound. So B scan. This is the ultrasound machine, This is the ultrasound machine. We are taking this. This is a general machine which radiologists are using for their ultrasound. So this is the screen, and these are the various modes. So it has all the modes what general radiologist people are doing for ultrasound. So we have this coupling fluid. We have these various probes are there. Now, for general ultrasound, there are different probes for abdominal and for other things. So, what probe we are using is a 8 to 10 megahertz probe. It's a linear probe. Normally, if we see purely eye ultrasound machines, so they have a little shorter probe, which is almost equivalent to comparable to the eyeball. So that moment we put it over the eye, so it just barely covers the whole eyeball. But since this is a general radiology machine, so this is a little wider probe, but we will do with this only, not an issue. So this is a linear probe as we are seeing. it has a mark. So this mark shows the top end of what we are seeing on the screen. So we go in, so these are the various modes and we will take the eye scan. Okay. And we want to keep the gain as maximum because we want to see all the layers. Yeah, so this is the gain I was talking about. If we reduce the gain, so we will see only those shiny things with high reflectivity. Let's put some coupling fluid on the floor. And moment we put the coupling fluid, you see the. I hope this video everyone is getting it. Are filled.
Yes, ma'am, the video is visible.
The patient is lying down. Sir, dish mein eyes closed, आंख बंद कीजिए. Normally, I prefer not to take the pillow because we want the position of the head to be horizontal. Okay, we are doing transclavally. Sorry, it's over through the lids. Above the sclera. Gently start the scan and just see the orientation of the globe. And meanwhile, we start seeing these images. You see the gains are maximum. I prefer to keep the gains maximum. If we keep reduce the gain, you see the echo start reducing, but then in this case, okay, we are not seeing anything, but where if we have something like a fibrous, heavy fibrous tract or a foreign body, so that will be shining and visible on reducing gain. So increase the gain again. So in anterior segment, basically we are seeing the posterior lens capsule shadows. Okay. And this is the whole posterior segment, the posterior segment of the globe, which is by and large anechoic. Gently we keep moving our probe and just to orientation, get the orientation of the eye and the globe. This is the posterior scleral shadow and optic nerve shadow. And then we look for any membranes or ecogenicity on the globe. The moment we start seeing any pathology, now we stop there and now we are working around the pathology. Different sections. Now, if you see here, now suppose we, in this case, we were seeing those shadows on one side. So now we start orienting our probe horizontally and medially to see where these membranes are seen. So here we look for the details of the membrane. See, these membranes are getting attached to some point, at some point attached to some temporal retina. So this means this is a case of vitreous hemorrhage. There's the PVD and the posterior vitreous membranes are getting attached to this point at somewhere in the temporal periphery of the retina. And there could be a small fibrovascular front which is kind of put in the retina. Take a printout of this screenshot. Unfreeze. You see these membranous fronts which is attached to the retina are now clearly visible. We take a printout. So now we tell Uncle ji, under seat, right left आंख घुमाइए. Right left आंख घुमाइए. So this is a kinetic sonography when we ask the patient to move the eyes and we look for movements of the membranes and after movements. If we come back to the patient side, now we focus here. Gently put the probe. I think you just need to refresh the fluid.
some little bit of coupling fluid. Gently put it on the globe to get the orientation and just move it up and down to get the whole horizontal sections, and then right and left to get transverse sections of the whole eyeball. And wherever we see the pathology, we can fine tune and narrow down and then look for that quadratic detailing. Starting with the ultrasound, what probe we are using is
like
a 10
we have
megahertz
seen this
probe. It's a linear probe. Normally,
one
if
minute.
we clean the probe gently, because this is also very important.
You have to take care of your probes and transducers also. So it's advisable after every ultrasound, you clean it nicely.
This patient is having fresh vitreous hemorrhage in one eye. He's diabetic hypertensive. In the other eye, there are very hardly any few changes of diabetic retinopathy, early hypertensive retinopathy. Now, in this case, we were in a dilemma. Maybe the cause of vitreous hemorrhage is some kind of a tear or probably a neovascularization. So that's what we have to rule out in ultrasound. Do we look for a horseshoe tear or some kind of tear in the retinal periphery, or we look for some neovascularization or a front or something?
Rather than, okay.
So that is what ultrasound gives us important information regarding the cause of this hemorrhage in this side.
So, okay, let us go back to the discussion, our clinical cases. Like this 45-year-old male already on treatment with physician for uncontrolled diabetes. He comes with diminution of vision in one eye, vision of just PLPR and 660 in other eye. He was diagnosed to have mature cataract. He was operated. He underwent an uneventful surgery. So what was the result? Nothing. The patient couldn't see anything after surgery. So what was the reason? The patient had a vitreous hemorrhage. There were some proliferations in the other eye also. So this is probably an indication, especially with diabetic patients, if the patient is having a mature cataract, you cannot see fundus. So the clinician, as a clinician, you should advise for a ultrasound in that eye, at least to prognosticate, to give prognosis to the patient. That is how this is the importance of ultrasound. And then one importance I've told you with tumors, intraocular tumors. And then we have another case scenario where a 65-year-old male having both diabetes and hypertension with borderline control comes with diminution of vision in one eye. He has low vision in right eye, whereas other vision is fairly good with minus 3.5 correction. Anterior segment shows early cataract both eyes. So moment you do a dilated fundus examination, you see this kind of picture where one eye has a total vitreous hemorrhage, maybe a fresh vitreous hemorrhage, you cannot see any details. And the other eye, now you see, if this was a purely diabetic or a diabetic retinopathy, you could have seen some advanced changes of DR in the other eye also. Whereas the other eye shows a fairly low degree, probably a non-proliferative, very early diabetic retinopathy. So this doesn't match with this eye. So you have to, immediately it comes to your mind that probably there's something else happening in the eye with hemorrhage. The cause of hemorrhage could be something else, not a diabetic retinopathy. So this is how, you have to keep the whole history and the whole thing in mind, that because once you know, only then you will be able to find some clues in ultrasound. So now with this background, you take the patient for ultrasound, B scan here, and you know that you have to look for some other things other than just a diabetic retinopathy. Maybe there's a horseshoe tear since the patient is myopic. Some HST must have come up, which has given rise to a hemorrhage. Maybe a BRVO or an NVE, or maybe a trauma, you never know. So you have to have things that what you have to look for. You have to know what clue that you have to look for in an ultrasound. So the reasons possibly Now you have to think yourself that what are the reasons, possible reasons for hemorrhage in this patient. It could be a PDR, it could be a vascular front, it could be a hypertensive retinopathy, maybe a venous bleed, or any retinal tear or a TRD because of some other cause, or any trauma or a foreign body, So once you go ahead with ultrasound with the clues and features in your mind, so that is why I've in my initial slides, when I said that it is important for the clinician to do the ultrasound yourself rather than just giving it to your technicians or to the radiologist. Only once you do it yourself, only then you will be knowing that what you have to look for, and you will have the best information. Like tomorrow, if I have to take this patient up for surgery, so I should know where the tear is, where is the front, where I will place my ports accordingly. So all these things are very important. So in the end, I will say ultrasound is a very handy tool for diagnosis, non-invasive investigation of choice. It could be just done like an OPD procedure. So very handy and very easy, and best done by the VR surgeon himself. So this is the whole importance of the ultrasound. Thank you. So
Thank you so much, ma'am, for that comprehensive talk on ultrasound and so beautifully showing all the images, as well as taking the time and effort to actually record the videos and showing us how to actually do the ultrasound scans. So I think that was a really comprehensive talk. Dr. Ankur, your comments, please.
Um, uh, that was a fabulous talk. You covered almost all the common pathologies of the retina, and you have covered how to do an ultrasound. It was a fabulous talk. Matlab, for every postgraduate, how to do an ultrasound, what are the important things that they should know. You have covered it all.
thank you.
Ma'am, we have a few questions from the students. One of the students has asked, how anterior can we visualize in the ultrasound the posterior segment? Can the anterior PVR be picked up with the ultrasound?
See, if it is a very anterior PVR, maybe with some thicker layer of coupling fluid, you can pick it up. Or otherwise, you have to go in for an immersion in ultrasound. I'm talking about really anterior PVR, but fairly much anterior PVR you can see on ultrasounds normally also.
And I think, ma'am, UBM can also be used for
Yes, then otherwise
picking up
UBM is
the-
a choice. Otherwise,
can be used for anterior PVR.
Sure.
So it will all depend on the type of probe you are using. So commonly what we use is a 12 hertz probe or a 10 hertz probe. So if you have an availability like Epaswamy provides, not to mention any company, some companies provide 20 hertz probe. So when you're using a 20 hertz probe, you will get a better resolution of the anterior
Then
images.
that means you're going towards a little bit towards UBM
Yeah,
only.
UBM is a 25
Yes,
and
that's
50.
what I said in my earlier slides also. There is a difference in, what machine you're using. These days, these ophthalmic companies, what ultrasounds they have, so they are purely ophthalmic ultrasounds. So they are mostly 10, 11, not 11, of course, 10 or 12 or maybe 15 megahertz. So unfortunately, if everyone doesn't have access to that, like what in my hospital, because it's a general hospital, so we have 2, 3 ultrasound machine for general radiologists, and we use that only. So they have 8 to 10 megahertz range for ophthalmic probes. They don't have higher than 10 megahertz. Then they have all the abdominal, ranges and all those things. So even 8 to 10 is a fairly good, we
Definitely.
get what information we want, but
Yeah.
definitely once you talk of anterior PVR, so then it's better, you will get a better information on 10, 12 or 15 or then UBM.
Yeah.
UBM is 50 megahertz, up till 50 megahertz.
I think it comes in
These are
two.
for the students
One is
I'm telling.
25 hertz and one is 50 hertz. There are two probes for that.
Yeah.
Yeah. So, ma'am, there's another question that is there any effect of positioning for the patient for when you're performing an ultrasound in an oil-filled eye? Like, should the patient be supine or should the patient be in a sitting position?
Oil-filled eyes are always difficult in the sense, difficult to get information. So what I do is I try all the positions. I start with the sitting position, then I make the patient lie down, take in a supine position, and whatever information, it's more on the assumption side. I have to assume all my interpretations actually.
Dr. Ankur, any comments from your side?
So this question is more pertaining to, I think, a person with a gas. And an oil-filled eye, almost if the patient is sitting or patient is lying down, it's almost the same. But then in a gas filled eye, if you have a partial gas filled, so if the patient lies down, you will not be able to see anything behind. So you make the patient sit in a gas filled eye, and if there's 30% gas filled, so you can do an ultrasound from the part which is not covering the gas. You make the patient sit down, the gas will go up, the fluid will be down. You can do an ultrasound. You look at the inferior RD or inferior detachment. But if you make the patient lie down, gas filled eye again, then you will not be able to see. So you can now ultrasound cannot travel through the gas. So this question is more important when you are talking about a gas filled eye rather than a silicon oil filled eye.
Okay.
Yeah.
There's another question that a lot of time CR thickening is mentioned, CRT is mentioned when the ultrasound scans are done. So how to make an interpretation about the CR thickening, chororetinal thickening?
That you can do once we have a combined A scan. This is the importance of having a combined A scan. You know, if you are purchasing a ophthalmic machine, always insist of have a machine with a combined A scan. Only that will give you measurements, and that is actually very useful.
Yeah. So I think a CR thickening is what we see in patients with chronic inflammation or pre-thicical eye is where we look at CR thickening. Ma'am, what value do you consider as significant for CR thickening, chororetinal thickening?
Mm, uh, I haven't actually gone through it, but because I don't normally take the measurements, I don't have that.
I think approximately 2 or
control with me.
2.1 is usually what they say. Dr. Ankur, any comments from your side?
So you're right when you are saying those figures. What I'm trying, what you even if you don't have the A scan module attached with the B scan, most of the modules that we have for B scan has an inbuilt A scan. But sorry, so they have an inbuilt A scan. So even if you don't have it, you can measure with the caliper the caudal thickness. And why how is it important is because if you are suspecting a case, then you are not able to see the posterior segment because of the patient having a complicated cataract. So the complicated cataract can be because of so many diseases, including uveitis. So if you see point like echos in behind, it might be vitritis, and if it is associated with increased caudal thickness, which you have mentioned right now, you can measure it with the caliper, and then probably you're looking at a patient of panuveitis. So these are the patients you have to be cautious by planning cataract surgery, because in these kind of patients, you can have an increased reaction, a lot of fibrin post cataract surgeries. So this is how it is important. At the same time, when you are suspecting a case of VKH, so before the having neurosensory detachment, these patients can have caudal thickness. So in the eye which is not involved, which is not showing neurosensory detachment, if there is an increase in caudal thickness, which can be measured on OCT as well, which is a more appropriate measure to measure the caudal thickness. But then if you have an increased caudal thickness in the other eye also, probably that eye also developing the VKH, the symptoms of VKH.
Yeah. There's
I
another
think
question.
here I have one point to say. Probably measuring with calipers is probably not a very good option, because that may not give you the exact measurements always. Because the picture that you are seeing on the screen, it can be little zoomed out or zoomed in, because it is not the correct replica of dimension wise. So
Yeah, so
maybe
if we have a B by
yes,
A scan, if we have a B by A scan combined,
then
that
yes, yeah.
can be a little helpful. So, ma'am, there's another question. Can the ultrasound pick up glass foreign bodies because they are non-metallic, not picked up by CT and X-rays? Can they
Yes,
be picked up by USGs?
yes, definitely. I've seen a lot of glass foreign bodies also, because it will show the interface, because that vitreous glass interface will be highly reflectile. So that will be picked up on ultrasound. And then, other things like little bit of shadowing and the trat and everything. Yes, you will see glass foreign bodies very easily.
Okay. I think these are the questions that I have received. Dr. Ankur, any questions from your side for ma'am?
Not exactly. I think it was a very nicely prepared talk, ma'am. And I think Pranita would agree that you have covered everything, and whatever questions that were left have been
I have
covered.
one question,
Yeah.
Dr. Pranita.
Yes.
Yes, sir, please.
Yes.
Yeah, ma'am, this is basically a question from a resident. If the examiner asks you, which is the
Mhm.
first line investigation for intraocular foreign body, CT scan or ultrasound, what should be the answer?
Ultrasound. Because CT scan, you don't want to expose the patient to a CT always. Ultrasound is very handy. It's there in your OPD and you can just do it immediately. But CT scan, you will send the patient after you get some clues from ultrasound. If you ask me the first line, there are two aspects to it. One is, if you ask me the best investigation, best is obviously CT. But if you ask me which is the first investigation, first line that you would like to do, best in your clinical scenario, I will say ultrasound. But of course, if you ask me best investigation, it is CT, definitely.
Yes,
But
ma'am. I think
But
it
moment a
definitely.
patient of trauma suppose a patient comes to me, I will first like to do an ultrasound because it is there, in my clinic. I don't have to send the patient to the CT department or anything. CT will take 1 or 2 hours till the time the patient will come back. At least I can have a first-hand information, at least some information I will get from an ultrasound.
Right, ma'am.
Mhm.
It is just
How
like I
accurate
see a
is
patient on slit lamp and indirect, and immediately I'll tell patient, okay, you lie down on the couch, and I will just see, quickly, just a minute or so.
ultrasound for detecting optic disc cupping?
Optic disc cupping.
Yes.
If the media is clear, I will definitely would like to do an OCT rather than an ultrasound.
I think this question arises from one of my residents because in EBC, when this corneal opacity,
Okay.
we tend to ask this cupping comment on. So I think this
You
question is
can
from
have
that
an idea. You
clinical.
can just have a reasonable idea, but of course not very accurate.
I think, sir, it's only an advanced cupping if the patient has that can be picked
Yeah.
up in the ultrasound if it's a 0.9 or a near total cup that the USG is able to
So
reflect
any cubitation, this is in fact we also practice the same. If you can see cupping on ultrasound, that means it's an advanced cupping.
an advanced
And
cupping.
these are the two questions from my residents.
Okay.
So
So,
thank you, ma'am. I think Pranita, you can conclude now.
yes,
It's
sir. So
already 8:30.
thank you everyone for joining us and with joining us and being with us for today, and Dr. Ankur for joining us, and ma'am for preparing that wonderful class that comprehensively covered everything related to ultrasound and the beautiful videos that you showed. So I think that is it, and our next class is going to be on 30th of December, where we are going to talk about ARMD and its variant. So looking forward for you to be with us for the next class as well. Thank you and good night. And thank you, Dr. Praful, for giving all
Thank
of
you
us an
so much. And I thank
opportunity.
the whole DOS, Delhi Ophthalmic Society, and the whole DOS team. And you all have been doing a wonderful job, to conduct these series of classes. And it's going to be like really useful for the students, the residents. Thank you.
Thank you, ma'am.